Good. I think our main question is if probiotic supplementation can improve depressive symptoms in treatment-resistant depression, right? So why we came up with this question is basically because now more and more studies show that microbiomes in the gut are very important. And second thing is gut and brain has a bidirectional connection, means anything that happens in the gut, the brain gets affected, and brain is depressed and the gut gets affected. And these signals, many of these signals are also controlled by the microbiota in the gut, right? So if you go down to the next slide, let's talk about that part. So in this background session, I was just talking about the things I mentioned. So gut-brain axis, there has been a lot of studies recently, especially over the last one decade, that we are knowing more and more about the enteric nervous system. That's the autonomic nervous system in the gut, as well as the brain connection. So what happens is that the bidirectional connection is that the nervous signals, the signals from the nervous system in the gut is sent through the vagus nerve, the spinal, neurons, and through that pathway it comes to the brain centers. And from the brain, the signals are sent through the hormones. So they use the hypophyseal pituitary adrenal axis, HPA axis. So that's how this whole loop is complete. So, the efference from the gut goes to the vagus nerve and the efference to the hormones. And many of the signals in the this gut is sent by the gut microbiome. That is the second part that I'm mentioning here. So in order for the homeostasis of the body to be maintained, so all these three things are important: gut microbiome and the gut-brain axis, brain and the gut. So the gut microbiomes are actually, they're like, there are some studies, I'm saying a little bit details, I guess you don't have to mention all these things, but just for, having that extra kind of backup knowledge is that the gut microbiome, they initially thought it's the number of microbiomes very high. It's approximately equal number of cells in our body. So that many number of microbiomes. And the gut, the normal gut microbiome has these healthy and microbiomes like the bacteria, fungi, and viruses. They're all in harmony in a symbiotic level, and they help to digest a lot of things. The free fatty acids, the large carbohydrate molecules, and like protein molecules, all those things are broken down by this gut microbiome, and then it helps the gut to absorb those things. So, and then these microbiomes also help to send signals to the brain in different forms. So when this balance is gone, then it causes various illnesses in the body, starting from inflammatory diseases, like if there's inflammation going on in the gut because of the negative, bad bacteria, then these, inflammations will cause all sorts of problems, including depression and anxiety. And also, as you look at the loop, we are talking about the gut-brain axis. There's this hormonal axis there, the nervous signals are there. So all those things get altered. And there are studies that actually found that dysbiosis or altered gut microbiome can actually cause psychiatric illness, especially anxiety, depression. Autism is also found to be associated with that, as well as it can lead to dementia and many other diseases. So this is why imbalance of gut microbiome is an important study area nowadays. So in this slide, I have mentioned some of those things. So about the enteric nervous system and its connections. So next is depression. So this slide, we just mentioned about the criteria. This is the DSM criteria for the major depressive disorder. You can look it up in the DSM. So I'm not going to go through that. And about the treatment-resistant depression definition. That is a little bit tricky because we don't have a consensus definition of the treatment-resistant depression. Many guidelines say if there is a failure of one adequate treatment, which means adequate doses for adequate duration, as as advised by the pharmaceutical company, whatever duration a person should be treated. But many guidelines also say it should be at least two adequate treatments failure. So sorry about the phone call. So we will, and then we know the treatment-resistant depression is a big cause of, fail, big cause of mortality and morbidity and loss of function, and it causes has increases the healthcare cost a lot, because when somebody is depressed, they are not able to find do a job, or can't even take care of themselves, sometimes needing to depend on the welfare or other support system. So this is why it's so important to address these issues. So this is why we chose, maybe this is an important area where we can contribute to the healthcare system by doing this. So now our hypothesis in this study is that we think the probiotic treatment will significantly reduce the symptoms of treatment-resistant depression. Because if we go back a little bit about what we know about depression so far, we are basically treating people based on our the monoamine hypothesis for depression, which means depression is caused by some kind of chemical imbalance between norepinephrine, dopamine, and serotonin. So we try to replace those with the antidepressants, right? And then we know some of these, like people get better, like about, if you look at the studies, like combination of medication like antidepressants and therapy with all ECT, with all those treatments, total of about up to 50 to 70% people get better. But there is always that 30 to 50% people who never get better. So this hypothesis probably is not applicable to everybody. So now we know that intestinal dysbiosis itself can lead to depression because of the disruption of the gut-brain axis, and also possibly because of malabsorption of the nutrients which are important for brain functioning. So if that is the reason, and if maybe the treatment-resistant depression is caused by that, not caused by the monoamine hypothesis, dysfunction, that this like the abnormality of the monoamines, but because of the disruption of the gut-brain axis or dysbiosis. So this is what we have been kind of trying to explore. So if we treat these people with probiotic supplements and we see improvements in their mood symptoms, maybe this is an area to explore, because this will actually change the whole hypothesis of everybody is being, all the depressions caused by these monoamine imbalances. So that is another thing which we will be able to know if we specifically target these treatment-resistant depression patients. Anyways, let's go to the next slide. And then this is, we made the study design here, so I'll talk a little bit about this. So as we know, probiotic is a very safe medication. People have been using this over the counter all the time. And what we will do, we will find the people who have been through depression, who, first of all, they are diagnosed with primary depression. The depression is not due to, for example, schizoaffective disorder, bipolar disorder, or secondary to organic brain syndrome, traumatic brain injury, all those things. We'll exclude those things. So the diagnosis should be primary depressive disorder. They should be already tried on at least 2 treatment modalities with antidepressants, most likely, and then not responding to them, and at least treated for 2 years. So we will take the people who are really not responding to anything. Secondly, they should not be undergoing any and they should not be undergoing any acute treatments that might impair, interfere with the probiotics efficacy. So we'll go over those a little bit later. But what I want to talk about here is that we will do the screening process, and we will have enroll the people in studies. But when we enroll, we'll be doing the screening, the first screening method only before the enrollment, so that we have the depressed patients whose score is at least 20 or over, 21 and over, because those are the patients who will have moderate to severe depression, according to the back depression inventory. And then we randomize them into two groups, with one with probiotic supplements, the other with the placebo. And this will be a double-blinded study, and we'll do the, baseline kind of assessments with physical exam that they have to do it with their family doctor or nurse practitioner, and give the informed consent, and then we'll enroll them. We will be, because this is more about, supplement. We are not going to change any of the mainstream medications, because with the treatment-resistant patients, if they are taking 3 different medications already, and we want to take them off of those medications just to give them probiotics, it may actually make things worse, because their body is so used to those medications, even though they are not working. Taking them off those medications will actually make it worse. So we will not touch anything that they're taking, and we will just supplement them with the probiotics, high dose probiotics, and our goal is to just replace the unhealthy bacteria with the healthy bacteria. And then the study will be for about 6 months time. And what we will do in terms of investigations, we don't need a lot of investigations, but we'll be doing also some fecal test, because we wanted to do some another test. Sorry, it's an accessory test. What is the word? I forgot. Exploratory test. We wanted to get some stool samples to see actually if the gut microbiota is different in this group of people, who have treatment-resistant depression, and if there's any changes at the end of the study. So this will be another, aim to do that. And then I was going to say it's just about the beginning, but do you want me to continue with the rest of the thing? Because I think, yeah. So I think we have to adjust the slides a little bit, because when I was talking, I was going kind of back and forth.
Yeah. Do you want us to keep on recording, or?
We can keep on recording. Yeah. Do you want to go up a little bit? I think what I'm thinking, we should probably, hypothesis, and then we have to get the eligibility criteria on top, right?
And then the study.
Study should be in the bottom, and then what do we have in the study? Yeah, we will put all those above, and the schema should be in the lower point. Right, then it'll be easier.
Yeah, I agree.
And what do we have? And then we can talk about the analysis and all those things.
Yeah.
Okay. Does it make sense what I was saying?
Like the
explanation of the
makes sense.
Yeah. Okay. I was talking a little bit extra things, but because of the time, we probably have only 7 minutes or something. So we have to make it shorter, so summarize. And but I was saying extra so that Elena, you have kind of that background a little bit.
Yeah, that's perfect. Thank you.
Okay. And then we can, if you want to practice, to do it within 8 to 10 minutes, then yeah. Okay, so going back a little bit, if you want to go up. So we talked about, okay, so after the, go up a little bit, go up that slide, yeah. So we will talk about the eligibility. after we talk about the, monoamine hypothesis and on those. So in terms of eligibility criteria, what we want to do is, first of all, they have to have the primary diagnosis of depressive disorder, right? And our age group will be 18 to 65 years. And we will do the back depression inventory in the beginning. And this is to, we'll take this as an eligibility criteria as well, so that we are, we have a score which is higher than 20 to have, the cutoff point for the moderate depression. We will also, so this will, the other scores will be not a part of the inclusion criteria. The anxiety criteria will not be a part of the inclusion criteria. We will do that, but it will not be an inclusion criteria. And no known allergies to probiotics. And then in terms of exclusion criteria, any kind of treatment that will interfere with the probiotics. So any acute treatment, for example, somebody on antibiotics, any steroids, or anything that might change that. And also any treatment with the probiotics recently, because that will change the gut flora already. And then severe other illnesses, right? Presence of severe comorbidities, which might influence the microbiota. And I'm also thinking we should probably add something. Oh, it will be more in the, I think, no, it'll be at the last slide where there is like, what do you call it?
The limitations.
Limitations, yeah.
Yeah.
The limitation, I just remembered something. Limitations would be, if somebody has a relapse of acute depressive symptoms for something stressful happening, we don't have control over that, right? We still have to
That's a good
include
point.
them in the study. Yeah. If somebody has, for example, a big loss in their family, acute relapse of depressive symptoms because of something, losing job, losing someone, loved ones, and that will still reflect their depressive symptoms, but we'll still have to include them, because once they're included, they're included. We can't exclude anybody or anything, right? So that might reflect it differently. We'll have to add it there.
Mhm.
Yeah. So then we talk about the study design, endpoints, right? Or what is it?
Yeah, endpoints and then
Okay.
the design.
So-
I think that's better flow. Mhm.
Okay. So then this is the study design. We already talked about that. So basically, just like for us to understand, I'm telling a little bit, I think, in detail. So for the study design, in the beginning, first of all, where are we enrolling these patients from, right? So we'll enroll them from psychiatrist clinics, family docs clinics, or mental health clinics, and then they should have a primary person to go to. We are just probiotic providers. We are not going to take any crisis calls or anything. So that should be included in our consent form, that they and also the agreement, whatever we make with them, that they should have their primary caregiver, care provider, whether or not it's a family doctor or a psychiatrist or mental health therapist, that they can go to. And they should also follow up for prescriptions with those doctors, because we will not be prescribing any of the other medications other than the probiotics. So that's one point, which is important. Then the screening, we'll do the screening. So basically the screening is for the criteria for moderate to severe depression. First of all, primary diagnosis of depression. There's no associated other psychiatric problems like schizophrenia or schizoaffective disorder or anything which might, that should not be in the, if they might have some other treatments, we are not excluding them. But what we are saying is the depression part should be from just depression, not from any other illnesses. And then the next part would be the randomization. I was talking to Jacqueline yesterday about how we do the randomization if they ask. So there's this, you know, computers and randomizations and those things they told us, I forgot, in our class.
Yeah, we can do the block randomization. I mean, I think that this slide is so busy that adding more to it probably doesn't make sense. So maybe Elena can just, you know, go over the standard block randomization scheme that people do for randomization, you know?
Yeah. So what I'm thinking, Elena, if they ask you how are you going to randomize, you just say that whatever, you know, they taught us. So, so that would be
Say what?
They have taught us something like how we randomize, like block randomization or something. When we randomize
Okay.
people.
Mm-hmm.
Yeah,
then,
we don't have to go into a lot of details, you
Yeah.
know, so I think it should be fine.
Yeah. And then we randomize them and both the patients and the physicians will be, or the caregivers will be blinded. They won't know what they're taking. And assessment wise, so we meet with them, we screen them, we randomize. And on the first point, day one, what we will do is we will ask them to give a stool sample if they agree. And then we give them the medication. That will be one contact. And then every 6 weeks, we're going to kind of follow up with them. So 6 weeks after the first day of treatment, we'll contact them by phone or by email, just checking how is it going, if they're taking their probiotics regularly, if there's any concerns. And then at 3-month time, we will be doing, that's the interim analysis. We can ask them to, we were thinking we should probably give them another forms for BDI and anxiety assessments. And then again, checking how things are going. Then 6 weeks after that, so that'll be 18 weeks, I think, right? Six weeks, yeah, 12 weeks, 18 weeks. So 18 weeks, again, just phone call or an email to check. And then 6 months time, what we will do is the final analysis. We'll ask them to give another stool sample, and then we'll ask them to do the BDI and the anxiety score. So that's all about our study.
Question, Prajita. Now, baseline at time 0, shouldn't we do a depression and anxiety assessment?
Yeah, there. Yeah, we are doing there at the first day, day one.
Here I don't see it. I just see laboratory.
Oh, we have to add that. Yes.
Yeah.
Okay. Sorry.
Okay.
Oh, you know why you don't see it? Because I moved it to the screening.
Oh.
Yes, it is because
Okay,
we
that's
keep
fine.
them both forms there, and we don't have to do it again.
Why would you? Oh, so you want to do it at screening instead of a baseline?
Yeah, because they might, if they are screening, they will get enrolled within a week of screening or something. Because I'm thinking, why I didn't want to put that again is because based on when we do the screening, for example, if their score is less than 20, we won't take them, right? This is why it's important that we ask them to do that at screening.
Okay.
And screening is not far enough away from treatment day 0 to need another assessment. Okay.
Yeah, that is what I was wondering. So, and also I see you put the yellow at the 6 weeks and 18 weeks. I don't think we need both of those two, but I don't know if you want to put a different color so that we just contact them. This will be more like phone checking.
Oh, you mean the depression and anxiety assessment?
Yeah, we are not going to do that on those two. We're just doing it 3 times. That one you can put probably another color just to tell them there was just a phone or email follow-up.
Oh, okay. Okay.
Yeah.
So at 1.5 months and okay, it will be a phone assessment. Okay.
Yeah, just to check in, just the compliance and those kind of things, right? So you can put a different color there.
Okay.
Pink or something.
Yeah. Let's see. Okay. Should I do?
We have a green, we have purple. We didn't have a purple.
Purple.
Yeah, that's good too. Yeah, green. Okay, so then this is all. I mean, our study is. So if we go now to the analysis part. Okay, so this is, I think Koske can tell the other slide about this one has changed a little bit. How do you think about it? How do you like this one? It was different before. Jacqueline, did you see the other one?
I did see it. Yeah, I mean, I think it's fine,
I just wanted to
yeah.
Talk about this too, the one before and this one.
Yeah, I think the sample size is fine.
Yeah, I think we can get rid of the data.
Yeah, that one they don't want us to.
Yeah, that it's something that I wanted to show you guys. Like, what I did. Basically, I took the number from prior studies, but it wasn't the PHQ score. It was the big depression inventory.
Yeah, we are doing a big depression here.
Oh, okay, yeah, and then in few studies, I think the effect size was about like 30%. So just if we use those numbers, it's gonna be around that number.
So should I just take this out here?
Yeah, I think so. I mean, some studies mentioned that so some studies mentioned that they expect some dropouts, so they used a higher sample size than what they calculated.
I think we should also expect that in our study.
Mm-hmm.
With depressive symptoms, often
we should consider dropouts.
Yeah.
I mean, you could say, considering, dropout, we will say we'll get like 100 in each arm or something like that. But I think it's sort of like an arbitrary number.
Okay, and maybe we should take this data thing out because they told
you can take it.
Once, yeah. And should we do it like more? We can do thumbnails or something for this one, or put it like points.
I don't think we need anything.
It'll be easier for us to for Elena to follow.
This should be.
I mean,
fine.
I mean, some studies just mention what we wrote here.
Yeah. Okay.
I think in some studies they add a little bit more patients, for expected dropout.
Yeah. So sample size of 86 participants for each group is deemed appropriate. Okay. So as we expect some dropouts, did you say like we should have 100 patients in each group? Or
it's usually like a 10% dropout. Is that?
I think 15 is good because we have other reasons they would have some loss to follow up to. So I think 100 is a good round number. If it is 15% dropout.
Okay. We have to just mention, I guess.
Yeah. Also, should we put the reference for the effect size?
Yeah.
We're approximating it to be 30%.
Mm-hmm.
Oh, okay. Yeah, I took from 2 studies. Let me just find out what those were.
Okay.
Are we putting numbers for the reference? I don't see them elsewhere.
I think we need to put numbers. Right now, we just have the references here. They're not numbered, but I guess they're appearing sort of in order. Is that right, Brigitte? Here, but we haven't put the numbers in the actual slide yet.
Yeah, I just, I mean, as it was, I just put them accordingly. I mean, I know I did some references.
So do you want to go ahead, Brigitte, and like put your numbers in the background slide?
Yeah, I can. do that.
So then, yeah, because I know where mine comes in after.
Okay, sure. All right, let's just get over. I think we are almost done.
Yeah, let's see. So we're here.
Okay, so this one, I just thought, so our primary analysis will be the back depression score, right? So I just made this chart. So basically, so there's pre-treatment and post-treatment in both probiotic treatment and placebo treatment. So that's how we'll calculate that. And then we'll have to do it like stratification, right? So we'll have to do it twice. And then
yeah, I don't think we'll use the chi-square or Fisher's exact for the analysis, right? Basically, we're comparing.
I didn't put that though.
mean.
I thought you put those.
No, this was there at the beginning, I think.
This test, I didn't put those. I just put these boxes here.
Oh, okay.
I didn't work on this slide.
Right. So I think for the primary analysis, we're comparing the mean score, right, of the Beck depression
Yeah.
inventory.
Yeah.
In that case, I think it's going to be t-test.
Yeah, we can all. I thought we can use the Fisher's test as well, but I don't know. This was not my idea anyway. So if you have put that, maybe t-test or.
Yeah, I think t-test is fine.
Yeah.
Easy.
Okay. So this, okay, let's put it then. Paired samples, t-test.
Well, I just want to make sure everybody's okay with it.
No, yeah, it's totally fine.
So I think for the first, we'll do, I guess if it's like, parametric, then it's t-test, but if it's not, it's like what Wilcox rank sum test or something like that. But we'll just say it's paired. I don't think it'll be paired sample.
Did you come up with the idea of the Fisher's test, Kosuke?
No, I think this was there at the beginning.
Because I
Yeah,
think that was the right. I think this was the right guess. That's why I was thinking, because I looked up the Fisher's test, and it says that you can do this in this. Let me go over. I can just tell you.
Yeah, I added that, and I also saw in a few papers that's why I had put it the Fisher's test.
Yeah, I thought it was a right guess. So let me just go over.
Yeah, because I think we're just assuming that at the beginning of the trial, both groups have similar mean score for the Beck depression inventory, right?
Yeah.
So I think what we'll be comparing is just a final score.
So if you're looking at the Fisher's test, okay. Do we have to mention this or no?
I think we need to, right?
Yeah, so what I see for the Fisher's test, it is, we can also do the chi-square test, but Fisher's test can be done in small sample as well as large samples. Okay.
Yeah, but I don't think we'll be looking at the 2x2 table, right?